Hi, so I'm here with David Joffe and Andrew Ewing from David from Sydney and Andrew from Sweden, and we are here to discuss the consensus expert report that they have just published about long COVID and long COVID. And so first, I'm going to actually let you introduce yourselves and where you're working, where you're from. So, David, why don't you go?
Thank you, and thanks for having me. I'm a respiratory and sleep physician, and I'm at Royal North Shore in Sydney. I'm also the vice chair of the World Health Network Long COVID Working Group, of which Andrew is the chair. And I work in non-invasive ventilation and spent a long time doing ventilation in acute severe COVID early on in the pandemic, and then shifted towards long COVID and its complications and presentations, really out of clinical necessity.
Okay, thanks, David and Andrew.
And I'm a professor of chemistry and molecular biology at the University of Gothenburg. My topic of research has been developing techniques and applying them to understanding the brain and neuronal function, particularly uh, synaptic function and exocytosis, and how that might lead to different aspects of learning and memory. So early in the pandemic, I realized that this virus was affecting the brain, and this is, of course, one of the long-term things. And I put together an early review for the World Health Network on COVID in the brain, also on the immune system. And eventually, I was recruited to this long COVID working group. We called it at first, and that uh, at one point I was then pushed to be the chair of the group. And so I've been leading this group of wonderful, fantastic physicians and scientists, and we came up with this idea to try to push this push the knowledge of what's going on in long COVID by using a Delphi survey of experts from around the world.
So
Um,
basically, Delphi surveys is a process by which you sort of collate the collective expertise of different people and see how it all sort of shakes out.
yeah, it's really a collective expertise, and we have the majority of the people in this survey are physicians. There's also a number of researchers in the area of long COVID. But the idea is to pull together the expert knowledge of this group and try to then put it into a package that we can use to educate other physicians and and of course rule makers and policymakers around the world. The Delphi process, the way we did it was an adapted Delphi process, a Delphi adapted Delphi process, because we started out with a round of open-ended questions, which is not normally the Delphi.
Hmm.
And so the first round was were questions that allowed us to develop the statements that we used for rounds 2 and 3, which was the official Delphi process.
Hmm.
And those are the statements that people had to agree with.
And so, what is sort of how many people were involved overall in your sort of in the process?
Uh, we started out with about 15 of us. That was about the size of the panel when we started. And I have to give credit. I mean, Ray Duncan, who's a fantastic cardiologist and physician in the UK, it was her idea to do this Delphi, because she was really getting frustrated with how many physicians didn't understand what was going on at all with long COVID, and it's very difficult to get treated and so forth. And so we started out with that group, and then we extended that group, and we ended up being about 30 people that were discussing what was going on, almost 30, and 179 people that experts that were on the panel overall. So it's quite a large group in something around 40 countries. It's in the paper, but it's every continent except for Antarctica. Couldn't
So,
ask the penguins.
So what were your overall conclusions? I mean, or David, anything you want to add to that?
Uh, no, except to say it was long and arduous, and credit to Andy for herding all the cats. Trying to get, I mean, most Delphi consensus published to date in the area of long COVID have only ever stretched to 30, maybe 40 people, and have largely been a cohort of local knowledge, either in America or elsewhere. So this is unique both in its scope and its size. It's the largest consensus opinion of almost 180 experts in the area from literally across the world. And so it is, without question, a kind of seminal piece of work in terms of the inclusion of so many people from, every continent. And I guess that speaks volumes about what long COVID is, and the fact that no country, no person, no culture gets a pass. Everybody is seeing it. So, I think that's one of the big messages, is that when you can get 180 people from every corner of the globe come and talk to you about what they're seeing and what they know, it tells you that this is really an enormous issue.
What I just want, sort of, for the sake of argument, what happens if sort of consensus tends to be wrong? Does the Delphi process sort of accentuate that? Or does that, some of the things that might be wrong get sort of weeded out in the process?
They tend to get weeded out in the process. So things that people don't agree with get listed further down from, rankings A through to B to C. But to be honest, it's also a kind of a living document. It's a kind of snapshot in time. This is at this point what we are thinking, where we think we should go. But it is not a fixed timestamp, if you like. It really is a work in motion. And so, over the course of doing it, we had to adapt and adopt, because there was constantly a stream of new evidence about various things that were, clearly hugely important, and shifted both the dynamic of the group and of the people answering the questions. And so, I think we have to appreciate that this is not a standalone body of work. It's really, but for Andy and I and the working group and the WHN, it's a jumping off point. And so many of the things that arise out of this are really the next step for us, from how do we educate clinicians to deriving teaching modules, learning modules, handbooks, specific papers about cardiac, neurological, and other things. So for us, it was really a kind of a jumping off point. And where do we have to go with this? And what are the areas that we really need to focus on to get both political but also academic and clinician experience? How do we teach our colleagues about what we've learned?
Well, why don't we go to
That,
that next? Because
that's
that
the
sort of comes
key.
to, I think, some of the major, conclusions or major findings, if you will, of the consensus. And I think they're listed some of them in the 10 points in the press release you put out. But Andy, do you want to go on from there?
Yeah, I can. I think the key thing in this, I mean, the reason that I thought this was one of the most valuable things we could be doing was to educate physicians, as I said before. And I think, I mean, and I don't mean that in an arrogant way. I mean, physicians are very, very busy people, and the general physicians need to understand where this stepping off point is, and when they see new patients come in, where do they transfer them to? And it just wasn't happening according to all the sources. The Delphi process, though, as you asked before, before I answer this question, I'm going to point out that all of the statements that did not reach consensus are listed in the appendix of the supporting information of the paper. So you can go there, and there's some very interesting statements that did not reach consensus. So there's some interesting takes that you can get from that as well. But I mean, the only statement that we had in the entire process that reached unanimous uh, consensus was that we had to educate frontline healthcare workers, okay, to recognize long COVID,
Hmm.
okay, and not just as post-viral fatigue, but as a complex and multi-system condition, and that it involves almost every system in the body, from the brain to the immune system to all sorts of organs.
What was
And I think
was the issue of fatigue another one of the problems that physicians tended to treat it sort of as fatigue in some sort of vague kind of way?
I think most
It's
still
a
do. Yes.
yeah. I mean, there's a component, and Andy and I have had this discussion many times. PEMS and, if you like, chronic fatigue manifestations are a component of long COVID, but long COVID is a different pathogen. It's uniquely consequent to, SARS-CoV-2 infection. And the more we learn, the more we recognize the multiplicity of ways that it damages people, from viral persistence to immune dysregulation to endotheliitis and microclotting, things that drive dyslipidemia, new diabetes, hypertension. We recognize its capacity to allow other pathogens to reactivate. And so, for many, the ME component is often thought to be in part EBV. And of course, if your immune surveillance system doesn't work, you get reactivation of those viruses. But there are some things that are really unique. So, the brain injury is really something completely different. I mean, we see dysbiosis in other patho pathological processes, from antibiotic overuse to inflammatory bowel disease and other things. But when you look specifically, as Andy started out with the brain, there are at least 8 ways, from direct neuronal death to autoimmune, to lymphatic obstruction, to dopa injury, hypoperfusion, uh, hems of the brain as well. So there are a whole host, at least 8 ways, that we recognize that this disease can clobber every organ. And the ones that really stand out, and that's why I guess we're moving to those specifically as part of our writing process, are really the heart and the brain. And to appreciate the implications of that in young people is really considerable.
So let's getting back to the consensus. So what were some of the other areas of consensus that you found among the group of you? And can David, maybe you can put what you said after in context of what some of those areas of consensus were.
Yeah, well, it's not just it's there, it was a very broad set of statements that reached consensus, and we divided this up into definition, because clearly there's an issue with the definition of long COVID being diffuse. I mean, we need to have a better definition. Diagnosis, because it's such a complex disease, we needed to understand, and we obviously need to understand diagnosis better. Treatment, we actually had better consensus in some ways, but it's still, we have quite a ways to go in terms of understanding this. In fact, a huge way to go. We then put into evaluation of treatment, how to evaluate when it's working. Research into several different categories, especially including children and organ damage, and then social and economic issues.
Mhm.
And we had consensus on all of these on many statements. That there's 10 statements or 10 conclusions that are in the press release.
Right. So you talked about it's essential to have a universal definition. And do you have any suggestions about how to come about that, or is that just something that you agree has to be done?
Well, part of the problem is that the definition has been symptomatic, and it has to be more broad than systematic. So it has to be It can't just be it has to recognize the fact that we're going to have downstream effects of this uh,
Hmm.
syndrome, and so it's really important to develop biomarkers for what's happening. It's really important to look for these extra effects that are taking place, and I think that's probably the biggest point from this. The National Academy's definition came closer to this than either the CDC or the WHO definition,
Hmm.
but it's still falls short.
Um, and again, the third one here on this list is it's not just tiredness. So that is something that you see a lot of physicians having that misunderstanding that it's just another form of tiredness, where people are just kind of
It's anything but. I mean, this term brain fog is just such an awful misnomer. It's brain damage, and there are a plethora of imaging studies, studies looking at the neurobiology, neuroimaging, immunofluorescence, clearly demonstrating that there is direct neuronal invasion injury, vascular injury, glial injury, and so you know there's a common misperception, and it's something that as a sleep physician you're always trying to tease out is the difference between fatigue and sleepiness. And for many, these people are not just fatigued, they're actually excessively somnolent. They sleep for long periods of time, and many, particularly the younger ones, have narcolepsy if you go looking for it. And for many, they have terrible insomnia, which means that their sleep is hugely disrupted. So they are very somnolent the next day because they are time shifted. They get inadequate sleep that doesn't allow their brain to clear poisons. And so there's much more to it. So when you say that word fatigue, to me as a sleep physician, that's both intriguing but much more complicated. You have to really try and separate out um, fatigue, as in muscle weariness, inability to physically do things, versus sleepiness and neurocognitive slowing.
hmm
Organ damage
So
in general. Yeah, organ
yeah,
damage in general. I mean, but the
yeah,
brain for sure, it's a huge part of this, and the heart. But I mean, we're finding basically the kidneys, the liver, the everything, even the the testicles in men. There's problems with menopause in women. There's huge amounts of things that are going on. It's way more than fatigue. But I mean, the fatigue is the brain effects, okay, and this are so debilitating. I mean, I watched a child lose a year and a half of high school that had to be repeated, okay, and then was on a plane trip, got COVID again, and sometime later, and ended up with PEM, post-exertional malaise,
hmm
which was last year in July, and still to this day is affected by it. So this is way more than fatigue. I mean, it's when you're somebody close to you, it's heartbreaking.
So what is the final, consensus of your consensus? I mean, what is the final takeaway that you would like people to have from your, what are your recommendations, I guess, going forward beyond the education of physicians and so on?
Well, I think the bottom line is, of course, to bring all physicians on board and policymakers on board because it's going to take money to do this. Another bottom line is to increase our awareness and the research that we're doing to try to understand this disease because it's so massive. We need to start to think more about prevention. It's really telling, though, that the physicians I saw on a Reddit post that was sent to me by a friend on the article that greater than 90% agreed basically that COVID is uh, causes long COVID, and yet only 67% to 77% of the panelists agreed that we should try to stop the transmission of COVID. And I mean, we need to get past that. I mean, we need to understand that this has to stop. Another thing is that we need to understand that children are at risk. The physicians overwhelmingly agreed that there was a problem and that we needed to research more what was going on with children. Children and young people easily get long COVID, and I think all
And
that what
and there's a myth that they don't. There's to some degree a myth that they don't.
yeah,
Yeah,
well,
it was the greatest fallacy. Probably, I think the greatest lie ever told, amongst many, was that Omicron was mild and we should all go back to work and back to the office and open schools. That was purely economically driven, Great Barrier Declaration and other things. Without question, the evolution from Delta to Omicron was the virus shifting from being an explosive lung predominant inflammatory condition that killed people and filled up, refrigerated trucks in New York and mass burials in Brazil and, pot banging in the UK. That was just to get our attention, David. It was to get our attention and we weren't listening. And the virus shifted to Omicron. And with that, it became significantly more neurotrophic. So probably the most neurotrophic was a really early vanilla Omicron called BA2 that clearly went straight up your nose and into your entorhinal cortex. And, that was for me the most ominous sign that it had shifted from wanting to kill us quickly. That's not advantageous for a pathogen. It's quite happy to bite you now and eat you later. And in the meantime, you're shedding it and spreading it. And, the risk of getting influenzas once every 8 to
the
12 years, you can get COVID 3 times a year.
I'm
yeah,
sorry.
and with children, as you're asking, I mean, this is just what went on there was more or less criminal. Because early
Hmm.
on, the severe symptoms before vaccination and before and the earliest Wuhan version of the virus, children were not as seriously at risk for dying. Okay, for the worst case scenario. But the fact is that in terms of long COVID, they basically have the same risk of getting long COVID, and this is very, very much needs to be dispelled. And I want to end by saying that this is it's not just a medical issue, as we say in the last bullet of the press release. It's a socioeconomic issue. This is costing enormous amounts of money. We're talking about a long-term costs in the trillions of U.S. dollars, and it's a medical system issue. And I think we need to pay attention to this more than we are. And if you don't want to think of it just in terms of humanitarian issues, then think of it in terms of the uh, economic issues. They're both tremendously important. And I think it's not just long COVID. I mean, long COVID there's a number of virus induced uh, uh, long-term effects that can take place, okay, and such as uh, the associated conditions of POTS and MCAS, insomnia. I think David said new onset dyslipidemia and diabetes, hypertension, ME/CFS. All these things are very important, and I think we need to have a lot more work done in terms of understanding these.
Okay. Well, listen, thanks, guys. I really appreciate it. And thanks for talking to me about it.
Okay, thank you. Thank you for having us.
Thanks, Dave.